Hi, Sarah. Can you hear me?
Hi, Melinda. Yes, I can hear you.
Okay, great.
Hi, can you guys hear me?
Yes, hi, Shannon.
Okay, I'm looking for Shannon Zaitis in the chat. I believe she was supposed to be the moderator for this session. But if not, we can just go ahead and get started. If she's not here, she might have also had technical difficulties.
And no worries. We can introduce ourselves if that's easier.
Okay, yes, if you don't mind, that might, work a little bit better. Thank you guys so much.
Okay. And hi, everyone. This is Melinda Neuhauser again, and thank you so much for rejoining after the break. And I'm thrilled to present with my colleague, Dr. Sarah Kabbani, from the Office of Antibiotic Stewardship. She's an ID trained physician and leads our work around older adult and nursing home antibiotic stewardship. And so today we're going to be sharing some of the work that we've been doing characterizing antibiotic use during the COVID-19 pandemic. Next slide. And we have no disclosures. Next slide. Okay, so as I just mentioned, we're going to describe how antibiotic use changed in the hospital, nursing home, and outpatient settings over the last year during COVID-19 pandemic. And we know it's been a year of many challenges. But today we also hope to discuss opportunities of how antibiotic prescribing can be optimized to improve patient care. Overall, there was significant variability in antibiotic use across the healthcare settings, with an increased prescribing in all settings of azithromycin, and then an increased use of ceftriaxone in both the hospital and the nursing homes. Next slide. We understand that you all practice in different settings where patterns of use will vary, as we'll soon discuss, but we'd really like to hear from you. And on the right-hand side with the three little bars, we have several polling questions. And so our first polling question is, have you been tracking the impact of COVID-19 in antibiotic use at your facility?
And I think, Melinda, the order of the questions, I think that question is the last one. So I think you all have to scroll down to the end to see it.
Okay, great. And okay, so we only have 9 votes so far. I know we haven't used this polling yet. Okay, well, I'm gonna call it 9 votes, including mine. And Sarah, did you vote too?
Yes.
Okay. And so you can see here in terms of the question. Oh, good. Here we're getting some more. 37 votes. There's a slight delay. So about 43% have been tracking antibiotic use at your facility, and about almost 60% said no. And then for those that have been tracking, our next question, which is in the middle, our question is, if you have been tracking, what was the overall impact on total antibiotic use over the past year? Has total antibiotic use, so for example, if you're in the inpatient setting across your hospital, has that increased, decreased, or no change? Okay, so far I see 23 votes. About 50% has increased, about 35% no changed, and almost a little higher than 13%, about 10% decreased. Okay, and then our last question, which is on top, is what has the overall impact on specific agents such as azithromycin and ceftriaxone, because we know these are commonly used for community onset respiratory tract infections. Has that increased, decreased, or no change over the past year? Okay, so we've definitely seen a high proportion of increase in these agents, which is consistent with the data that we're going to present with you today. Well, thanks for participating. We'll have one more poll question, I think, later. And so today we are going to provide a snapshot of antibiotic use data from different healthcare settings during the COVID pandemic. The hospital use data will come from roughly 1,500 hospitals participating in CDC's NHSN antimicrobial use option that we discussed in the previous session, or the Premier Healthcare Database, whereas the nursing home data comes from about 1,900 facilities that contribute to long-term care pharmacy database called PharmAmerica. And then the outpatient data comes from a proprietary data source called IQVIA, and this reflects national estimates extrapolated from data that covers 92% of all retail prescriptions in the country. So we're really excited to be able to present not only hospital but nursing home data as well as outpatient data. Next slide. Okay, so here's a slide from the NHSN hospital data from January to December. In the solid lines are data from 2020. In the dotted lines, that's data from 2019. And you can see here that total antibiotic use on the top lines rose a bit in March and April in 2020, but then went back to baseline or slightly below in May, and then remained stable throughout December. And then azithromycin and ceftriaxone use were higher in 2020 than 2019 for all months reported. You can see that the use rose sharply during the spring COVID peak, went down, then rose again during the second summer peak, and then continued to be somewhat elevated through the end of the year. And these increases in the use of ceftriaxone and azithromycin certainly make clinical sense, as providers had been faced with huge increases in the number of patients presenting with community onset respiratory infections. And though most of these patients maybe had COVID, we know that distinguishing COVID from community-acquired pneumonia can be challenging, and these prescribing patterns reflect that. This next slide shows aggregate hospital antibiotic use for piperacillin, and you can see it compares 2020 to 2019, and the top bar graph is from the National Healthcare Safety Network, and then the lower bar graphs are from the Premier Healthcare Database, and these data are from January through October. And you can see that the aggregate hospital antibiotic use for piperacillin was mostly lower in 2020 compared to 2019 in both of these data sets. And a similar trend was seen for vancomycin. Next slide. This manuscript described aggregate antibiotic use for hospitals with increasing numbers of COVID discharged from the Premier database. Most hospitalized patients with COVID received antibiotics. About 77% of patients hospitalized with COVID had received antibiotics, and over 80% of these were started on admission. So almost half had received ceftriaxone, and this was often frequently in combination with azithromycin. And for this analysis in the next upcoming slides, you're going to see the data is by quartile, and the lowest quartiles are the ones with the hospitals with the lowest number of COVID discharged per 10,000 patient days, and then the highest quartile, quartile 4, is those with the highest number of COVID discharged per 10,000 patient days. And so this represents the hospital-wide antibiotic use data with the Premier, and you can see that hospital-wide antibiotic use data was actually significantly lower during this March through October 2020 timeframe compared with March to October 2019. And this was for overall, as well as specifically for the hospitals with the lowest burden of COVID-19. Next slide. And here's a similar framework with the Premier database, but for azithromycin. And in hospitals with a higher burden of COVID-19, the azithromycin DOTs per 10,000 patient days was higher, with increases really shown within that quartile 4. And this difference was observed not only for azithromycin, but also, data is not shown, but for ceftriaxone, cefepime, and doxycycline. So you really see an increase with the largest number of increases in the median difference observed in hospitals with progressively higher COVID-19 burden. Next slide. Now, when you look at piperacillin, tazobactam, it was consistently lower in 2020 compared to 2019 across the hospitals, regardless of the COVID burden. And this data is not shown, but this was also consistent with vancomycin and levofloxacin. And so now I'm going to pass it to Sarah, who's going to be describing antibiotic use in the nursing home and the outpatient setting.
Thank you, Melinda, and thank you everyone for joining today, and we appreciate the invitation from the conference organizers. So we looked at nursing home prescription data from a long-term care pharmacy data, and as you can see, similar to the previous hospital graph, the dashed line is 2019, or the continuous line is 2020. And in the top part of the chart is all antibiotic use. So when looking at all nursing home prescription data, we saw a small decline in overall antibiotic use. This decline may be attributed to changes in resident population. Those of you who practice in nursing home setting have seen that during the pandemic, there were shifts in resident population with decline in elective procedure, potential declines in short stay populations, especially early on in the pandemic. We suspect and hope that improved implementation of infection prevention and control measures could also have played an effect with a decrease in transmission of respiratory infections, but so that could have also contributed. Now, if you look at the bottom part of the chart, you see azithromycin and ceftriaxone prescribing, where similar to hospitals, there was an increase in prescribing of those antibiotics prescribed for respiratory infections. And you can see that those peaks in prescribing correspond to COVID activity that was happening early on in the pandemic with lower peaks, but they still parallel COVID activity. Whereas if you shift to the outpatient setting, there was a much more significant decline of antibiotic prescribing in 2020 compared to 2019, and as you can see in the red chart. And this likely reflects several factors that could partially be due to changes in healthcare utilization, but also because of all the mitigation measures. The decrease in transmission of respiratory infections probably has played a significant role. But if you look at azithromycin specifically, there was a relative increase in azithromycin prescribing early in the pandemic, and that remained higher than expected in the winter of 2020. one important point to make is that secondary bacterial infections appear to be uncommon in patients in COVID-19, especially on presentation to the hospital. Early on in the pandemic, we didn't know, but now there's increasing literature characterizing the incidence of secondary bacterial infections. A meta-analysis estimated that the overall proportion of COVID-19 patients with bacterial infection was around 6.9%. However, if you look at bacterial co-infections that are estimated on presentation, that number is even lower at 3.5%. And in fact, a multi-center study found that bacterial respiratory co-infections specifically were uncommon at the time of hospital admission at 1.2%. That said, we know those patients end up having a higher illness acuity and longer length of stay, and that can lead to the subsequent development of healthcare-associated infections and the spread of antibiotic-resistant pathogens. A retrospective cohort of hospitalized patients with COVID-19 found that 7% had a proven or possible HAI after admissions. As you all suspect, risk factors include ICU admission, dexamethasone use, severe disease, and underlying conditions such as heart failure, but also antibiotic exposure on admission. We mentioned earlier, and you all have been living through this, the COVID-19 pandemic presented challenges, but also potential opportunities for healthcare public health professionals to continue stewardship activities. And we initially had a poll question for you here. We wanted to gauge some of your reactions on how the COVID pandemic affected your ability to perform traditional stewardship activities. But Melinda, I don't think we have that one. Right?
Actually, yes, I can see that one.
Actually, we do.
Mm-hmm.
Yes, we do now. I think it appeared.
So we do. First question. Excellent. So if you go to the polling questions, do you feel that your ability to perform traditional stewardship activities has increased, strongly decreased, somewhat decreased, or generally no effect?
Can you see the responses, Sarah?
Yeah, I can see at 21, almost half are saying somewhat decreased, a third strongly decreased, but a good 20% has no effect. And this is interesting because some of our published literature so far echoes some of that. So this graph is from an abstract that was presented last month at the CSTE conference, where researchers surveyed community acute care and critical access hospitals in Colorado to describe the impact of the pandemic on their stewardship program. And as expected, the COVID-19 pandemic shifted resources from stewardship programs and reduced dedicated time, specifically for pharmacists, as you can see in the middle bar, and in the red section with a 53% decrease. Specific stewardship activities such as audit and feedback were more affected than others, such as pre-authorization. And another presentation that was given is by the Michigan Hospital Safety Consortium that surveyed 51 of their hospitals to characterize the impact of the pandemic on stewardship activities. And similar to Colorado, almost all reported some decline in activities, with a quarter characterized as strongly decreased, and where antibiotics stewards shifted their time to the care of patients with COVID-19. And I'll hand it back to Melinda so she can discuss some opportunities for improvement.
Thank you. And I know in our previous session, I focused on the CDC core elements and that they provide the structural and procedural components of stewardship programs across the setting. So not just that not just hospital, but also outpatient nursing homes. And you may consider us biased, but we consider that the core elements can be adapted to optimize the diagnosis and treatment of community onset respiratory tract infections, including COVID-19. Next slide. I know we often already discussed that distinguishing COVID from community-acquired pneumonia can be challenging in many cases, and the hospital core elements outline diagnostic considerations and opportunities for improving the treatment of community-acquired pneumonia as highlighted here. And we're also working on a project with IDSA to create a clinical pathway that will start kind of in the context of the ED in an operational setting for diagnosing respiratory community onset infections, and then gearing towards appropriate use for CAP therapy, of course, when it's not COVID. And so we're hoping in the upcoming years that we'll have more opportunities to partner with organizations such as IDSA to create operational tools for not only in the inpatient setting, but also in other settings like the outpatient and nursing home. And I also wanted to highlight that the outpatient core elements outline activities that can help providers optimize treatment of respiratory viral infections, including for the treatment of patients with COVID-19. And Sarah, did you want to discuss some of the literature on this topic?
You know, we wanted to highlight some of the studies that are coming out now on this particular topic, and this was done by by your neighbors across the street. It's a single center quasi-experimental study of adult patients admitted with COVID pneumonia, where the Antibiotic Stewardship Program developed a guideline for antibiotic initiation and discontinuation for community-acquired bacterial pneumonia in COVID-19 patients. And they incorporated those guidelines into the institution's inpatient COVID-19 management guidelines. So after that intervention, 42% of patients received empiric antibiotics, but that was compared to almost 75% of patients pre-intervention. And the median DOTs post-intervention was 1.3 days shorter than pre-interventions. And specifically, antibiotics directed at atypical bacteria, DOT was reduced even further by 2.8 days. All outcomes were statistically significant, and what's more important, that there was no difference observed between groups in terms of clinical outcomes. And again, this is a small study in a short period of time in a single center, but it just reemphasizes that opportunities for improvement of treatment exist for these patients when admitted to the hospital. We just want to reemphasize some of the principles we discussed, that measurement of antibiotic prescribing, both at the local and national level, remain important to identify trends and opportunities for improvement. Again, echoing Melinda, we may be biased, but electronic reporting to NHSN AU antimicrobial use option is important for hospitals to monitor antibiotic use. The COVID-19 pandemic has underscored the importance of infection prevention and control and antibiotic stewardship to protect patients against antibiotic-resistant infections, especially hospitalized and nursing home patients. And investing in building capacity within healthcare facilities, but also at the state and local health department to improve antibiotic use and prevent antibiotic resistance, both for traditional and non-traditional settings, such as telehealth, which we are now engaging more with, remains critical. And I think Melinda already put the plug in for our U.S. Antibiotic Awareness Week coming up that we all hope that you engage with us in, and we're happy to take your questions, and thank you.
Great, thank you, Sarah. If there's any questions, if you want to put them in the chat.
Yeah, we have about 5 minutes left, 5 to 6 minutes left. So feel free, any questions, any comments, please put them in the chat.
We're scrolling down and looking, and we appreciate everyone engaging with our questions. And it's really nice to see that, this sort of this informal quick survey somewhat parallels some of the other things, some of what we've seen nationally and what specific states have reported. And I know this was probably mentioned earlier, but our slides will be available for everyone to download tomorrow.
Sarah, do you want to, I know you showed the data, but do you want to maybe just highlight which data has been published from a CDC perspective?
Yes, no, definitely. So we.
If you want to speak a little louder, I'll go on mute too.
Okay. So we've published some of the outpatient data, however, early in the pandemic. So the outpatient data that you see here through the end of December has not been published yet. I think we published through August, but we have forthcoming publications for that, and they'll be shared soon also on our website. The data that Melinda shared with you from Premier. So this manuscript has already been posted early in June, and we're currently have a manuscript under preparation to share the NHSN data. The nursing home data also has been published, but that was through October. However, we're looking forward to update as we learn more and looking closer at prescribing in patients with COVID, so we can provide more input for providers on prescribing practices.
Great, thank you. So we do have a question here. Any specific suggestions of how LHDs may access AU data, for example, outpatient and long-term care settings, to inform education and outreach efforts? Sarah, do you want to maybe address long-term care setting first?
Unfortunately, we don't have national data yet available on the CDC website for long-term care settings. And we've worked with pharmacy partners to get an estimate of a subset of facilities, and that's what we've been able to share. That said, engaging some of these pharmacy partners locally within a collaborative of a group of facilities may be at this time the best approach for long-term care settings. In terms of outpatient data, I think the IQVIA data that we've shared is posted on our website, on the CDC website, on the patient safety portal. So that is available for state and local health department to look at. And
great, thank you. And then there's a comment from that some practitioners use azithromycin for COVID stuff. That could have been a reason for increase, as in absolutely early on there was some suggestions that it was effective, but and so I think maybe, like from a hospital perspective, there was higher peaks of azithromycin early on in the pandemic. So maybe, once some of that was dispelled, there was less of the prescribing for that reason, rather than just more of a complicated respiratory community onset picture.
Yeah, but that said, in some nursing home and outpatient setting, although we saw the largest peak, as you said, with earlier in the pandemic, but there was some persistence of use where we think at least some of this prescribing is potentially inappropriate and can be avoided. So, and that's some of that early suspicion of effectiveness unfortunately persisted, and we hope with better communication and we can address some of that as an opportunity for improvement.
Yeah, absolutely. Thank you. Okay, well, I don't see any other questions, and we're basically out of time. So Thank you again for the opportunity for the CDC to present earlier today on updates and participate in the panel discussion, and then also show some of the projects that we've been working on characterizing antibiotic use. And we have one more CDC colleague that will be presenting later this afternoon in the breakout session discussing COVID vaccine in a long-term care setting. So thank you very much.
Yes, thank you all so much for joining. Please head over to the next session. I believe it's Sarah Green's session with the top 10 papers on antimicrobial stewardship. We hope to see you there. Hi, everyone. This is Shannon again. I just wanted to let you know that the next session has started. So if you're still seeing this black screen, you can go ahead and move on to the next session. Sarah Green is presenting on the top 10 papers in antimicrobial stewardship from 2020.